Good morning, good afternoon, good evening, buenos dias, bonjour. On behalf of Tropical and Geographical Neurology Specialty Group of World Federation of Neurology, Indian Academy of Neurology, and Forum for Indian Neurology Education, I welcome you all for this second session of WFN Neuroinfection Series 2. The theme for today is CNS tuberculosis, and it is the most important but the huge topic. And to enlighten us, we have eminent speakers. I welcome the speakers, Dr. Suzanne Marais, Dr. U.K. Mishra, Dr. Osheik Seidi, Dr. Renaud Van Crevel. Dr. Suzanne did all the hard work to organize this session. Thank you, Suzanne. This session is organized by Pan-Africa, Pan-Arab region. I welcome Dr. Augustina Charve-Feli, who is the President-elect of African Academy of Neurology and moderator for the session. To chair this session, we have Professor David Bolwer. He is a professor of medicine at University of Minnesota, USA. He is an infectious disease physician scientist with formal training in clinical trials, public health, tropical medicine. And his primary research interest is meningitis in resource-limited areas, including diagnosis, prevention, treatment, and quality improvement initiatives. Current research is focused on improving the clinical outcomes of HIV-infected persons with cryptococcal and TB meningitis. And for last 15 years, he's in active research partnership in Uganda. He has led numerous multi-center randomized clinical trials in Africa, and he's to NIH HIV co-infections and cancer study section chair for last 2 years. And warm welcome to Professor David. In the room we have to present the case Dr. Kate Macmillan from South Africa, and welcome her. We have the past president of WFN, Professor Raj Shakir, Secretary General of WFN, Professor Wolfgang Griswold, Professor Sarosh Katrak, Secretary IN, Dr. Gagandeep Singh, Dr. Rahul Kulkarni. I welcome. I'm sure you will enjoy this session and the series. And now I hand over the mic to Professor David and Professor Suzanne to carry further proceedings. Thank you. Dr. Suzanne, you are going to invite the next speaker?
Yes, our next speaker. Can we have his CV up, please? Prof. Seidi. Okay, I'm very thankful to invite Prof. Seidi to introduce Prof. Seidi, who's a professor of neurology and internal medicine at the University of Khartoum in Sudan, where he's a senior consultant neurologist at Soba University Hospital, and he's also a senior consultant neurologist in Riyadh. He was previously a consultant neurologist in the UK, and he was also a clinical research associate at King's College. And he was a founding member and vice president of sorry, now I've lost my slide. Hello?
Hello, yes, I'm following you.
Oh, sorry. Now I just lost my slide, but I'll interrupt myself then. Please continue.
It's all right. So shall I make a start? Hello?
Yes, yes.
Please.
Yes.
Yes, please start.
Shall I just make a start?
Yes, please.
Okay. First of all, thanks to everybody. Thank you, Mr. Chairman. Thank you for the invitation. And what she wanted to say, I'm one of the founding members of the African Academy of Neurology, which I feel proud of, and proud to see that they are invited in this session as well. And we are very happy with the collaboration we are getting from both the World Federation and from FINE. I have been saved a lot by my previous two colleagues, Professor Suzanne and Professor Misra, with their comprehensive experience. And probably they made my life easy. So probably I'll go into filling gaps into the clinical presentations of tuberculosis of the nervous system other than tuberculous meningitis. These are very interlinked conditions, so I might be touching in and out on what they have already said. I don't have anything to disclose. Although this is a very busy slide, I will probably not go in everything, but it's for the benefit of those who want to review what else apart from tuberculous meningitis. So the central nervous system is the most known for people, but many don't give much attention to involvement of the peripheral nervous system, which I will also touch on and probably show you one very rare case. So I'll talk about tuberculomata, or some people like to call tuberculomas, and TB brain abscesses, cerebral vasculitis, and meningitis already has been touched on by my previous colleagues. Tuberculous cerebritis, TB in the spinal cord could be post disease, which everybody knows, but it could be also less known variants of radiculomyelitis and non-osseous spinal tuberculomas and chronic spinal arachnoiditis. TB of the orbit and the retina also is interesting and useful clinically. And in the peripheral nervous system, you can see granulomata on the peripheral nerves, entrapment which can involve cranial nerves, and can involve the radicals in the spine or directly on the peripheral nerves, either from the direct process or from the cold abscesses. I'll show a rare case of lump over some peripheral nerves, which I believe I did not see it in the literature before, and I hope you will, some people will have an input on that. The complications have been expertly covered by Professor Misra, and they are either of the disease, but I will touch on hydrocephalus. Other associated disorders that have been covered, absolutely fantastic. Iris, HIV immune status. So I will not indulge into that at all. I will not talk about the atypical mycobacteria, and I will hint on what to expect in the future. This is our hospital. Soba University Hospital in the outskirts of Khartoum was donated by the Soviet Union in the 1975 as a hospital for tuberculosis, and then evolved gradually into a tertiary care center, university hospital with multiple specialties. And I'm sure some of the audience, they have already visited this. So tuberculomata, they can occur in the context of tuberculous meningitis, or could be the sole presentation of involvement of the nervous system by tuberculosis, particularly in immune competent patients. I don't see much patients of HIV, but I see other immune competent. They are not immune competent, but they are HIV negative. Particularly, we see a lot of refugees in Sudan and internally displaced people due to the raveling civil wars around Sudan. I'm sure people do see this in other parts of the world. And I think refugees and internally displaced and malnutrition and the gap in food in the world is going to cause more and more cases of tuberculosis. So it's not only treating TB, but treating the social circumstances might be the way forward. The epidemiology in many of the countries is not very accurate, but estimates go from 5 to 10% of patients with tuberculosis have extra pulmonary, and those with masses in the brain, 5 to 30%, they have tuberculosis. So it's a quite important problem, and it's well shown in the global tuberculosis report by the WHO. It's available, I'm sure you will go through it. The clinical approach to patients with tuberculosis and other parts, I think for the benefit of trainees and benefit of those who don't see much patients, particularly our colleagues in the developed world. So they have to consider the language barrier. If somebody's coming from India or from Africa, sometimes they don't give very good history. So it's important to get an interpreter and also mind the local body language, because if I move my head from side to side in Sudan, it means no, while this causes problem, because it is absolute yes in India. So usually the symptoms are headache, fever, local symptoms, seizures as mentioned previously, and change in mental state. Could be just confusional state, or even the patient might come in a state of coma. So you have to be very careful on the spectrum of the presentation, but a high index of suspicion should be kept in. So patients who lost wait unexplicably, or they have night sweats, or they have I saw many patients who just came with neck pain and night sweats and then turned to have tuberculosis. Close to this is the very young and the very elderly, and as I mentioned, the other groups of. In the West, probably those with alcoholism and those who are homeless are high risk of tuberculosis, and keep an eye open on this. So not easy sometimes to diagnose just from the history and even with the investigations, as Professor Susan mentioned. So prison mates in the West and probably travel history, it is important to ask people about exposure to contact with open cases, or if they have lived or originate from a high prevalence area. And this is important for our colleagues. So you are not immune from seeing very funny cases with tuberculosis in any part of the world, in all populations. In the physical examination, if you see wasted patient with temperature or altered consciousness, meningeal signs are usually minimal in patients with tuberculosis, though you can see them with TB meningitis. I did not try the new head jolt test. Probably Professor Shakir might comment on the use of head jolt in patients with suspected meningitis later. And the signs go from high up down. Fundal examination is important because it can show tuberculosis or resistant tracheal pressure, see papilledema. Sometimes you observe a focal seizure, and I call that a vivid sign. You see focal seizure probably, even if the initial scan is normal, with fever and sweats, you have to suspect in the right context involvement with tuberculosis as in tuberculosis. And the address goes without comments from me for the focal signs. General examination might give you a clue, but not all patients who are having extrapulmonary will have very vivid or clear chest signs. So even if there are no other signs, still you have to consider this. The differential diagnosis goes with the infectious causes, but non-infectious causes should also be considered, because not all patients coming with this, even with the fever and night sweats. So think of partially treated meningitis. In our context, sometimes patients just go to the primary care center, get antibiotics for a week or two, and then they come 2 or 3 months later with partially treated meningitis, or even longer than this. Brucellosis is a great mimicker of tuberculosis. So not all patients coming with these are only tuberculosis. I did not see any patient with co-infection with brucellosis and tuberculosis, and I would like to hear from people. Keep in mind fungal, spirochetal, and other agents. Probably when I show one of the cases, I'll tell you what I think of another differential also, which people should consider. Recurrent viral infections, like particularly also we see patients who use very strong, powerful immune modulator medications for multiple sclerosis or for other gastrointestinal or rheumatological conditions, and they come with PML, so JC virus screening, and even sometimes it's very difficult, even with the investigations. Tumors, either primary or secondary, particularly cystic astrocytoma and glioblastoma multiforme. I'll show you one case of possible meningioma, lymphoma, leukemia invading the central nervous system or involving the retina, might be like that. Elderly patients coming with headache, elderly lady, as they do have high SR, don't forget, giant cell arthritis could be the cause rather than tuberculosis. But the CSF will help in such cases. Non-infectious vasculitis involving the central nervous system, radiation cerebritis and meningitis, demyelinating disorders, even multiple sclerosis. In our context, sometimes we don't suspect it, and it's rare in the environment in sub-Saharan Africa. So we do see lesions which enhance, but these are actually due to tuberculosis. In other places, or even in Africa, still MS is there. So not every lesion you see in that context should go only for tuberculosis, particularly if the other tests are negative and the CSF was clear. So I saw one patient with tuberous sclerosis, CT scan with contrast, typical of tuberculosis, started on anti-tubercular therapy, but when seeing the patient, actually the patient has classical skin manifestations of tuberous sclerosis, so that was stopped, and the patient was told that's not tuberculosis. Basic blood tests can help, particularly the ESR and the CRP, because they might be raised. I will not indulge into the hematological manifestations of TB, but HIV test is important. CSF routine, already being covered, and I will not comment on the microbiological tests. Imaging is important. It's not available in all contexts, but a CT scan with contrast might give the answer in many cases. MRI and MR spectroscopy, when there's difficulty between differentiation between a tumor and this, I will show some evidence for that. Not to forget dural sinus thrombosis sometimes, patients with retrocranial pressure or even hydrocephalus. If you do CT scan with contrast, you might see that there are clots in the sinuses as a complication. Tissue, CSF is a tissue or biopsies from lesions. Sometimes we are stuck. We don't know whether this is tuberculoma or this is a tumor or something else, and might need to go for a biopsy. This is done in very few centers, and I'm sure it's not very available in many of our countries. Somebody asked about the Mantoux test or the PPD or the intradermal test. The intradermal test is not very helpful in patients who are immune compromised, but in immune competent patients, in about 50% of the patients are strongly positive to the extent that it's more than 3 millimeters. Some records say this might indicate active infection. Honestly, I don't do it. I don't think it's very valuable. It might be helpful in population studies to know the prevalence of the positivity, but I don't think in individual case, it will make you sure enough to convince the patient on a prolonged and not without this medication for a long period. So Procella testing, and I remind people if it comes negative in a context, for example, now I practice in Saudi Arabia, people do drink raw camel milk sometimes or goat milk, and you think it's tuberculosis, but if you do Procella test, it comes negative, unless you mention to the laboratory, we need in high dilution, which will overcome the Brozone phenomenon, Lyme disease, and the other vasculitis. So one point I want to raise for trainees, that when not to do a lumbar puncture. It's easy to say any patient suspected, we do a lumbar puncture. I remind all these colleagues, lumbar puncture is safe in the hands when it is selected properly, and it should be done in every patient suspected to have CNS infection. But if there are focal signs, or the patient is unconscious, or there is papilledema, you have to be extremely careful. And you do imaging. After doing imaging, if it confirms the presence of a space occupying lesion or midline shift, then you cannot do a lumbar puncture because the risk of coning is high. And as I mentioned, neurosurgical services are not at hand. So probably that might be killing to the patient rather than the disease. And I always go for empiric anti-tuberculosis therapy without any delay. So be careful. So tuberculometer, with the MRI scan, you see big lesions, and usually they have strong ring enhancing. So we always remember the mnemonic of MAGIC, which is the differential diagnosis basically of brain ring enhancing lesions, and I'm sure everybody has gone through this previously. Sometimes it is mimicking meningioma, which is based on the surface, and the clue to that is not enhancing uniformly, and there was massive edema around it, and it has a core which has reflecting different parts being iso intense, while others are hyper and hypo. So this is a clue to this, but in the right context of having the clinical features of fever, night sweats, or weight loss, and very thin enhancing. I think this also comes from the Great India. I won't go in the details of MRS, and I'll leave it for those who are talking about the diagnosis, but there is a lipid peak in patients with tuberculoma. This is not conclusive. We had difficulties sometimes with MR spectroscopy, although they say a single peak at 3.8 pp per minute as potential marker to differentiate them from malignant tumors. Honestly, sometimes it is very difficult, and we go by empiric or for biopsy. Also, when there are multiple tuberculomata, you have to consider cystic causes. Again, say magnetic resonance imaging and spectroscopy might help, and the peak of lipid and also reduction in the choline and N-acetyl aspartate peaks might help to differentiate. This study is shared from Sudan and two of my colleagues. Tajuddin Sokarab and Muhammad Najib Idris participated to 24 new cases, and with using spectroscopy, and again they also used blood flow studies. It did help in some of the cases, but here you can see this mass crossing the midline. So whether it is glioblastoma multiforme or not, then in these cases they claim this will help spectroscopy and the flow. Again, we have to make our students and our trainees aware about all these possibilities. Goals for tubercular brain abscess, the differences between tubercular abscesses and granulomata are not great, but the center of the abscess is non-reactive. It's a liquefied center with a thin wall. Usually it can occur in any part of the brain, but predilection to the centrum semi-ovale and the brainstem. So it can present with fever, headache, and raised intracranial pressure, obviously by obstructing the CSF and causing obstructive hydrocephalus. Again, you don't need to take biopsy from this, and if there's midline shift, probably a lumbar puncture might not be possible. Again, I won't repeat saying that we look for the urine test and how sensitive it will be, and implement it in many of the patients. Hopefully, it will be also available and supported by WHO or other organizations or TB campaigns to make it available. The problem is these abscesses can rupture into the ventricular system and cause severe ventriculitis. And this is a devastating condition, which will also cause hydrocephalus. And most of the patients who ruptured in the ventricular system, they passed away. I saw around 20 cases or so. I think almost 18 of them passed away. And sometimes it's also difficult to differentiate tuberculosis from biogenic. Again, MR spectroscopy, and they say the peak of lactate is higher in patients with biogenic rather than this. And when it is very difficult, patients are started on empiric antibiotics for conventional biogenic abscess. If no response, then they are changed in my context to antitubercular therapy. I think this is very risky. We still look for easier, non-invasive diagnostic tests to differentiate between the two, because MR spectroscopy, again, I don't think it's available in many parts of sub-Saharan Africa or in rural India or in poor parts of the world where tuberculosis is more common. I always say it doesn't look like anywhere in the world the confluence of the blue and the white Niles in Khartoum, and this is an invitation for all of you to come to Sudan and see it yourself. Tuberculosis of the orbit, it could affect the bone, the soft tissue in the orbit, or the retina itself. So there are many case reports of patients having involvement of the bone only. So plain X-ray showed destruction of the lesser wing of the sphenoid bone, and later an ultrasound showed that there was an abscess dragging there and causing compression. So they can come with 6-nerve palsy, combined 6-nerve, or cavernous sinus syndrome, or proptosis, as in this patient. So keep an eye for the possibility of tuberculosis. Plain X-ray in the rural areas or in the resource-limited areas will give an answer. Choroidal tubercles, more seen with miliary tuberculosis now with a sophisticated test, and they are raised, and they could give clue to the diagnosis. If you see a patient who are very sick with pulmonary tuberculosis or in an area of high prevalence, probably this is basic clinical skill, and it will answer difficult cases sometimes. So they are clinically significant. They denote that the patient probably has miliary tuberculosis, and we see them rarely in immune competent patients. Bilateral, more with these, and again, these are our visitors to the department. And tuberculous cerebral vasculitis is a devastating sequelae of tuberculous meningitis and has already been mentioned by Professor Misra, but it could be direct involvement or it is the immune response, as in the iris syndrome. Many patients who came like this, actually this happened after the patient was started on tuberculosis therapy. Not only this, he mentioned also the stroke, and it's worth also mentioning that some patients when started on tuberculosis develop adrenal crisis. They become severely hypotensive plus other factors. So an eye should be kept open about cerebral vasculitis complicating tuberculosis. This patient had dural sinus thrombosis, blocked the left transverse sinus. The question here and the problem we face is the interaction between anti-tuberculosis therapy and anticoagulants, particularly warfarin. So the balance is difficult, but we usually go for both and monitor the patient's INR closely. Tuberculosis rhomboencephalitis probably happens in the context of tuberculomata within the brainstem, which is not very clear evident with initial investigations, but it is not an entity which I'm very comfortable saying that it exists on its own. I think it's always in the context of TB meningitis or tuberculomata, and I would love to hear from other colleagues. So mixing it also with rhomboencephalitis caused by listeria in immune-compromised patients or in young or elderly, I think one should keep an eye, but CSF in listeria is characteristic, and I think the blood glucose will be low in both of them. So we have to do the Nielsen staining and PCR probably. If not, we add penicillin to the anti-tuberculosis therapy if we are stuck. Tuberculosis of the spine, famous, everybody knows about, and usually it is either osseous or non-osseous, so it can be the bone being involved in the juxta disc areas with cold abscesses and collapse, probably mechanical. It can involve the blood vessels are called vasculitis, local vasculitis, venulitis, or involvement of the subdural venous plexus, spinal venous plexus. Can also be caused by direct involvement of the spinal cord. So it is non-osseous involvement. And chronic spinal arachnoiditis cause chronic low back pain, but the clue is in the right context, high-risk areas, fatigue, weight loss, and night sweats. One has to consider this, and MRI is usually very characteristic without any involvement of the disc or the bone. I won't go into the differential of this. Peripheral nerve granuloma has been reported, but it's quite rare. And this patient, this is the right sural nerve biopsy. Somebody came with pain and dropped foot and all steroids and all this did not work much. Biopsy done, and the patient improved on anti-tuberculosis therapy. The clue was the patient had tuberculosis in the past few years before. So one has to ask about history of exposure. Entrapment neuropathy, secondary tubercular abscesses is very known. This South syndrome can compress the femoral nerve or the coda equina. And this is the rare case which I have seen myself. And initially, I thought this is not tuberculosis. And you will see the video. The video plays very well. Does it play well, the video? Did the video play well? This is the lower part of the this case. So they are much together, and aspiration was very positive for us at fast bacilli. MRI showed only one disc involvement, and the rest was a soft tissue mass which did not liquefy. But this is, I could not find any such case in the literature. So the abscess dragged across the intercostal nerves, and the patient was generally well without gibbous and florid symptoms. He responded very well to anti-tuberculosis therapy with steroids, and the lesions resolved. So I won't talk about the management in details, but antimicrobial, also the general care, nutrition for the patient is important, and osmotherapy has been mentioned already, and early rehabilitation. I think early rehabilitation is also very important in our context. It does not need very sophisticated interventions, but sometimes also we need the help from the surgeons, as in abscess drainage, excisional biopsies, spinal decompression, or reconstruction with bone grafts. Complications of the disease, and this have been mentioned, hydrocephalus will be either communicating or non-communicating. The non-communicating is usually complicating subarachnoid block due to the involvement of the meninges and the arachnoid villi, the subarachnoid space by the pus material, more around the brainstem. Non-communicating, direct obstruction, as I mentioned. Dural sinus involvement will also raise the intracranial pressure, and I will not also go in details of this. Hydrocephalus in tuberculosis could be either with this or reaction to the start as part of the paradoxical response to anti-tuberculosis. So sometimes the patient have a small tuberculomata. You start the treatment, the patient develop hydrocephalus. So it's either being close to the aqueduct of Sylvius or the fourth ventricle, or probably at the foramen of Monroe. Probably, you know, the fish focus of the primary could be in the arachnoid species of the ventricular system. Again, it needs intervention. Paradoxically, you have already been mentioned several times. Tuberculosis radiculomyelitis as part of iris has been mentioned by Professor Suzanne, and they have shown their own case. This one I got from the literature, and again, it shows almost the same as the case presented. So it could be reaction, it could be both obstruction due to mechanical and iris. These patients who are having terminal involvement or conus involvement in the context of Sudan always think of bilharzia. So we give them praziquantel dose, which doesn't have much side effects. But we did see in young patients, particularly who they swim in the canals, they come with conus syndrome and urinary retention, and they don't respond to anti-tuberculosis, but when given anti-bilharzia. So teamwork, more awareness, more courses, and networks will be the way forward. I think the general awareness, BCG vaccination for patients, I think now BCG is not given in the West, but in our context should be emphasized that we do this, and I will look forward also for the new therapies. I'm just wondering, why not people think of lesser drugs like 1 or 2 medications for mycobacteria? I would like to hear from others, and more sophisticated tests, which non-invasive, particularly in the urine or the saliva or whatever, to give advanced neurosurgical stereotactic also, and endoscopic relief is not available in our context. Target rehabilitation. This is target rehabilitation in a patient in a rural part of Sudan. He's paraplegic, and there are no paved roads. So what we did, we got this wheelchair and we connected it to an us. And actually, he had anti-tuberculosis therapy, and he's back working, and he is the breadwinner for a big family. We showed this in general practical neurology. Also, campaigns providing patients with wheelchairs. We also asked donors, civil organizations to help. And now I would like to call, if people agree with me, for a task force against neurotuberculosis. Probably I will leave this in your safe hands. And this is the 7th European Academy of Neurology, the regional training course in Khartoum 2015, where all these elites came and educated us about, many part of them was about tuberculosis of the nervous system. And the way forward is collaboration. Thank you for giving me the opportunity. I hope I delivered something of meaning to you. Again, Soba, pyramids in Sudan, and the lovely confluence of the Niles. Thank you so much for listening to me. And I repeat my gratitude to those who organized this meeting. Thank you so much.
Great. Thank you very much, Professor Osheik. Our last speaker is Professor